Assessment of drug efficacy. In this video, I'm going to discuss the Cochrane collaboration risk of bias tool version 2, and this is also a continuation of the Ivermectin story part 2. Hi, I'm Dr. Manimala Selvi-Naika. I'm a consultant histopathologist and statistician. A disclaimer first, I don't treat patients directly. I'm a lab medicine physician. Now, firstly, what is risk of bias? What is bias? Now, for example, if the true mean weight of doctors in hospital A is 60 kilos, and if you do a study and you get a result of 55 or 65, that is bias, right? Now, in real life, we do not know the true value to compare with. So we have to depend on the fact that we do the study correctly without bias to get at unbiased results. So I had a look at the Cochrane risk of bias tool. This is the latest version of it. Now, to be very clear, as this tool was being developed, there were a lot of clinical doctors, medical doctors involved in it, right? So it is not entirely something just by mathematicians or statisticians. But the editing of the final version of it was done by mainly those from mathematics, right? Now, so there's no medical doctor in the house. Now, the problem with that is doctors and mathematicians don't speak the same language, right? So, though the mathematicians are very well intentioned in this risk of bias tool, but you can quite easily pick out that doctors may not understand what they're trying to say. So, the domains that they assess for risk of bias are the randomization process, bias due to deviation from intended interventions, missing outcome data, measurement of outcome, and selection of the reported result. So the first one, bias arising from the randomization process. Now, I've got to say this is clear-cut wrong, right? Because selection bias, that is randomization, is a very different concept than control, which is baseline imbalances. Remember, it's randomized control. So you have to achieve both parts independently. Whereas in this, they have conflated the two issues. Now, I understand what the mathematicians are trying to do. They're trying to help doctors come to a conclusion. And to be fair, they say that, doctors can always override their algorithm, right? So that is there. But the fact remains these are two essentially different processes. So you can't have them as one unit because one doesn't depend, you can't predict whether the randomization went well or not based on imbalances in the baseline. Now, let's look at the workflow. You need two pieces of information to call this a randomized control trial. The first question is, was it randomized? Now, randomization is composed of random number generation and allocation concealment. They come together, right? So it's either a yes or a no. There's no maybe and things like that. It's a yes or a no. And this yes or no is based almost entirely on documentation and audit of processes, right? Now, the second question that needs to be answered is a biological one. If the randomization was indeed done and done correctly, did you get two biologically equal groups, right? Because to do the control study, logically you need two equal groups on either side. So, and in humans, the balance often depends on the size of the group. The more people you randomize, the more balanced the groups become and the homogeneity of the participants. Let's say you go to a army camp like Tranda or something like that. All the recruits there are mainly young, fit Malay, males, they are very homogeneous. So you can achieve good balance with a small number of participants, unlike if you go to a supermarket where you need a large number. So a lot of authors may not understand that this is in fact two distinct and separate uh, concepts, right? And just because somebody wants to call their study a randomized control trial doesn't make it a randomized control trial. So this is not a bias. This has to be assessed first before going on to the risk of bias, because this is very fundamental. Now, again, the process of randomization can create two equal groups, right? If it's big enough and the participants are homogeneous enough. So what is the theory underlying this, right? Now, if we keep randomizing people to two groups, um, and we measure some parameters like either the age or the height or the weight. Now, if whatever we can measure is balanced, then we can take it that, or we can assume that whatever we cannot measure will also be balanced because it went through the same process. It's like cooking rice. At the end of the process, you just need to sample 1 grain of rice. You don't have to sample the whole pot because they all went through the same process. So, um, getting a balanced group through randomization is basically that process. But they are two distinct processes. So, at the end of assessing whether selection bias was eliminated or not, that means your randomization was correct or not, and whether you have got two well controlled groups or not, right? So once these two questions are answered, you can decide whether you have the group in pink, internally well controlled trial. So this is your classic randomized control trial. Here you can assume that because you know that the measured variables are balanced, the variables which are not measured are also likely to be balanced. Now, the benefit of being able to assume this is because whatever the size or the magnitude of your effect is, you can have high certainty that it is the true magnitude, right? On the other hand, if you did not achieve your perfectly well controlled study through randomization process, maybe it's a historical control or something like that, you may have no reason to think that the two arms of the study are not balanced, but at the same time you have got no methodology to make that assumption either. So that's the difference. So when you have a well-controlled trial which is not the result of randomization, you usually have high certainty only if the effect size is large. For small effects, it's very difficult to be certain. And regardless of the process you have gone through, randomized or not, if the study arms, the two biological study arms are not controlled, that means they are not equal, they are not similar, you have to have a very large effect size to be certain that it is the true effect, what FDA calls as compelling evidence, right? So there are some very dangerous words in this document, uh, which may be perfectly clear to a mathematician or statistician, but which can mean different things to a doctor. Now, the first thing is the word on average, right? That phrase on average. Now, to a mathematician, it means that if I repeat the study repeatedly, 100 times or infinity, using the same trial participants, I randomize them and give them either the intervention or the placebo over time, right? The mean of all these repeated studies will give you the true mean. But to a doctor, on average, a doctor will not be repeating the study hundreds of times, right? It's only one study and that's it. So to a doctor, very often it means if you have 4 diabetics and 3 hypertensives on this arm, that will be balanced out by having 3 diabetics and 4 hypertensives on the other arm. No, it does not balance out. balance is about biological similarity, regardless of the process that it has undergone. So the other dangerous words here are yes and probably yes, and they are taken to mean yes, and no and probably no are taken to mean no. So there is a lot of imprecision introduced into the review process. That means different people are going to come up with different impressions about the same study. The other thing is the doctors are asked to guess whether what do you call it, uh, event took place or not, right? Whether it likely happened or not. Now, very often these things cannot be guessed, right? It's as simple as that. Now, so the second bias they are talking about is deviation from intended intervention. Okay, now this is where your risk of bias starts. The moment the patient holds the medication in the hand till the outcome is measured, this process must go well. Because if this process doesn't go well, regardless of how well your randomization and how perfectly controlled your trial arms were, your result will still be biased. So this is where the risk of bias actually starts, right? Um, so this is for the effect of adhering to the intervention. So they have got two different ways of calculating, which is common. One is the intention to treat, and the other one is per protocol. Now, both of these are dependent on blinding of the patient or carer and blinding of the doctor who is treating them for other things, right? The reason being, if a patient knows or suspects that he or she is receiving or not receiving a treatment, he or she may do something. Like many people enter clinical trials because they want the active treatment. So if they don't get it, they may just buy it online. So at the end of the day, you might find that both your arms are doing well because both groups have been buying. I mean, one group got it from the pharmacy, from the trial, and one group bought it online. So both are doing well. So you can't, what do you call it, uh, easily assess what went on in the trial. One, you must be a specialist trained in that particular area, right? If you want to assess a ICU trial, you must be an ICU specialist yourself. So you know what are the kind of things happen in the ICU, what nurses do. And the other thing is, if it's you're going to assess something where it happens in the community, you need to be a local doctor. One good example was the Colombian Medina study, where later on there were comments that, in Colombia, you're able to buy ivermectin, on the street. So patients who didn't receive ivermectin also likely went and bought it themselves and took it. So both arms showed good effect. So there was no difference in both the arms. So sometimes you may need people with certain specialized skills or people from or local doctors from that particular area to assess this. So in the ivermectin study, they were all German doctors. So I'm not sure whether they would understand what would happen in ICUs or in the community in other countries. So this is just what do you call it, a chart showing that you, as long as you evaluate as per the randomized group, you have your per protocol, that's those who actually took the medication and intention to treat everybody regardless of whether they took the medication or not. Or you can also analyze as treated, whoever took the medication in one group and whoever didn't take the medication in the other group. So that's basically just a cohort study, right? Now, for most doctors, if there is too much missing data, they will not be interested in the intention to treat. Now, this is another very dangerous area because they ask you things like, uh, does the missingness likely depend on the true value and things like that. These things are unknowable to a review author. They are unknown and unknowable to a review author, right? Now, the bad news about uh, missing data is there is no remedy for it. right? No remedy for missing clinical data. Now, if you impute clinical data, that is basically fabricated data. So you can use it in small quantities just to fill up some spaces and basically save your data set. But fake data is fake data, whether it's legally fabricated or illegally fabricated. Now, from what I see from the advice given in the manual is this seems to be a generic risk of bias for all kinds of interventions. That means it is an intervention for they expect it to apply for interventions for active drugs, like giving ivermectin for symptoms, as well as to generic kind of intervention like carrots. Does carrot prevent carditis? Like brinjals prevent bursitis, kind of things. So on one hand, active drug interventions are usually smaller studies and the patients are very closely followed up. Medical ethics committee usually wants someone, when you give someone an active drug, they want the patient to be followed up closely because if the patient fades or dies in the car park or something like that. So if you look at the principal trial, they expect you to have a study partner. That means somebody else they can contact if they cannot contact the study participant, right? So missing data is not a major problem for active drug studies, right? And if it becomes a major problem for some reason, too much of the data is missing, such a study is not analyzable. Okay, you cannot use intention to treat per protocol and all that because there's too much of data missing. Of course, if it's a very huge study, 30,000, 40,000 and 2 or 3,000 are missing, you still have what do you call, you can still do per protocol and it will make some sense because doctors also can compare data not just to the other arm but also to historical data. For example, if we know that 30% of patients with sepsis die ordinarily, but in this study it shows that only 10% of patients die. So regardless of what the other arm shows, you know that there is an effect. Okay. So generally, if there is a lot of missing data, nobody is interested in the intention to treat analysis. Okay, this is my favorite chart. There is no remedy for missing data, so please do not ask doctors to guess whether the value of the missing data, the missingness is dependent on the value. Now, there are two types, there are actually four types of missingness, but textbooks usually talk about three. So I think that, that has to be clarified as well. There are actually four types, okay? One, whether or not it's correlated to other variables, and the other is the mechanism of missingness. Now, whether it's correlated or not, you can do a test like Little's test. So basically, if you have data from missing from males and females, and the missing kind of data is both high and low data, that would be your missing completely at random. If the data is only missing from males, but still it's high and low values which are missing, then that is known as missing at random. Now, whether the data is missing at random or missing not at random is not knowable, okay, to the investigator, and definitely not knowable to the reviewer. The only remedy you have is to randomly sample the missing patients and go after them and measure the outcome. If you find that in a random sample both high and low are missing, then you can deduce that it's probably missing completely at random or at random. And if the amount of missingness is sufficiently small, then you can impute, but otherwise missing is missing. Now here is bias in the measurement of the outcome, and this has got another very complicated thing where you have to say whether it's likely or not likely and things like that. Okay. Now, discounting fraud. Fraud is a different thing altogether. If the assessor is blinded and the measurement is objective, there is usually no bias, right? Even if it's subjective, it's no bias. But don't forget that there can be measurement error. Objective measurements also can have error, subjective measurements also can have error. If the assessor is not blinded and the measurement is objective, there's no bias. If it's subjective, there is a risk of bias, not because they want to be fraudulent, but because they like the drug ivermectin so much, they may keep on saying that, it's working, it's working. So this kind of thing, it's very hard to say accurately. So a lot of reviewers, they just give you their own impression. It's not a fact. It's just their impression. So that is something that this risk of bias table can be very inaccurate. Now, the other one is bias in selection of the reported result. This is not a risk of bias, right? Now, and in a study trial, they may collect hundreds of different results, but they may report some. Now, if they say they are going to report something and then they don't report it, then that is a risk of bias. Then you will ask, why are they not reporting it? Was it that it was not favorable to the outcome and all that? But if they never said that they are going to report such a result, and then for you, then the reviewers cannot say that just because the reviewers felt that it ought to have been reported, so it is a bias. For example, if you're looking at a study which records that, then look for that kind of study, look for that in the aims of the study. If the study doesn't say that they plan to report that, then for the reviewers to say that, that a study which doesn't report that is not a good study is wrong. Now let's go to the ivermectin question. Now, as I said, I don't see patients, so I'm only going to do the prevention study because that is common sense, which any doctor should know. I can't do the ICU studies because I'm not because of bias, because I might introduce errors into the interpretation. Okay, so this is what they did. They were looking at ivermectin compared to no treatment for prevention of SARS-CoV-2 infection. And they've recorded the study, Shoumann et al. In 2021 from Egypt. And they said that all-cause mortality up to 28 days, not estimable, 1 RCT and very low quality. We are uncertain whether ivermectin reduces or increases all-cause mortality up to 28 days. So I went and looked up the study, right? I think it was done in Egypt. So they say that they did a randomized control study, ivermectin versus no ivermectin, and they only followed up the groups for 2 weeks to see if they developed symptoms suggestive of COVID-19. So that was the study aim. Did the patients for the patients given ivermectin, did they develop symptoms suggestive of COVID-19? They never said that they are going to look for death. Right? So in this particular study, initially they were randomizing to both arms. Then they found that the ivermectin arm was doing better. So as it's expected ethically, they stopped the other arm and continued with the ivermectin arm and just assessed the ivermectin arm. And that's perfectly normal, right? And ethical thing to do. And they used a clinical history of COVID-19 as the outcome. They didn't use RT-PCR because at that point in time, that was their diagnostic criteria. So this is their result, their main results. They first randomized 57 and 26 cases, but 5 cases on the ivermectin, 5 index cases on the ivermectin arm and 2 on the non-ivermectin arm were considered missing outcome data, and that's quite a small number actually. So I'm sure they tried their best to track down this patient, but they couldn't. So the results were, now I call this an externally well-controlled trial. I didn't call it an RCT because on the paper I did not find any evidence that this was an RCT. But the Cochrane review authors have put this down as an RCT. So I assume they did their due diligence and asked the authors whether the randomization and the allocation concealment was done correctly or not. But for me, I want to be on the safe side. I just put this as a non-RCT. Okay, and we found that 7.4% of the ivermectin arm became symptomatic and 58.4% of the non-ivermectin arm became symptomatic. Okay, now to me, this is what FDA would call as compelling results. So whether it is a randomized control trial or non-randomized control trial, the results are compelling enough to override any deficiencies in the manner in which the trial was conducted. The only thing I would be worried about is because this is non-pharma study, the data has not been audited. So I hope there is no fraud involved. But as long as there is no fraud involved, and or rather there is no data errors involved, as long as that is not involved, this to me is very compelling results. Okay, it overrides any deficiencies in the way the trial was conducted. So what did Cochrane say? So they said they took the study which doesn't even aim to look at mortality data and said that the study did not estimate mortality data, and they put the grade as very low. So we are uncertain whether ivermectin reduces or increases all-cause mortality up to 28 days, when the study never even looked at that. That was not their main aim, right? Now, what am I trying to say? If you want to look at mortality at 28 days, look at a paper which assesses that outcome. So it's no point looking at a paper which says that they are going to look at whether they become symptomatic at day 14 and say that their evidence is useless because they are not looking at what you want them to look at, right? So I think this is very symptomatic of the I mean, in the sense that it's just basically a misunderstanding of this risk of bias assessment tool, right? Now, so the take home message is, from me is that if you want to look at drug efficacy, it's better to read the original article yourself to see if it meets your requirements, right? Because when other people look at it, and when they're looking at many studies, you know, 30, 40 studies, they probably will get things wrong. And I also went and did a bit of searching around to see how easy other people found this risk of bias tool to use. And there's this paper here. They also presented it at the what do you call, one of the Cochrane conferences. The revised risk of bias tool for RCT showed low inter-rater reliability and challenges in its application. I think they went on also to do a small subgroup where there were more specialized studies with the concerned specialists, but they also admitted that they had the statisticians next to them to refer back to, right? So this is a problem with the risk of bias tool. One, it's probably not written with doctors in mind, doctors who don't understand statistics, so it's hard for doctors to understand. Number two, it doesn't emphasize the fact enough that medicine is very local. Clinical medicine is very local. If you want to look at a Malaysian study, you need to get Malaysian doctors to look at it, because only they will understand certain things which a common practice or common risks of bias in their settings, and somebody else from another country may not understand it. So the thing I found about the Cochrane ivermectin study was that almost all of them seem to be Germans, right? Okay, thank you very much. This nice picture here, I copied it from the internet, so thank you to the owner.